Okay, welcome back. Sorry about that interruption. Let's get back to penicillin's mechanism of action. So what happens is this penicillin enters the bacteria via the cell wall, and it disrupts the synthesis of the bacterial cell wall. Then it competes for and binds to this specific enzyme protein, this penicillin binding protein, and that catalyzes the transpeptidation and the cross-linking. So the enzymes to which they bind then are implicated in these final phases of building and reshaping the bacterial cell wall while it's growing and dividing. So once this has occurred, then the biosynthesis of these structures that the cell needs to make its cell wall can't happen. And so bacteria die because the cell lyses. And penicillin doesn't kill other cells in the body. It's pretty specific. Indications for penicillin, as we said before, include the treatment and prevention of infections caused by those susceptible bacteria. Adverse effects. Allergic reactions to penicillin occur in 0.7 to 4% of the treatment of all courses. What we see is urticaria, pruritus, and angioedema. Those allergic to penicillins have an increased risk of an allergy to the other beta-lactam antibiotics. But that being said, only those patients with the history of throat swelling or hives from penicillin should not receive the cephalosporins. Our common adverse reactions or adverse effects, are nausea, vomiting, diarrhea, and abdominal pain. Other adverse effects are actually less common. It does interact with many medications, including our NSAIDs, oral contraceptives, really important for patients to know, warfarin, and there are many others. With our penicillins, we also want to think about the high sodium content of some of the parenteral penicillins, like the carbapenems and the ticarcillin. They can be a danger for patients who have renal or cardiac conditions. In infants less than 3 months old, we want to make sure we investigate the history of penicillin allergy in the mother. And our pediatric renal tubular function appears to mature more slowly than the glomerular filtration rate. So penicillins are secreted by the renal tubules. So we need to make sure that clearance is there before we can give those medications. So when we think of renal clearance, we want to make sure that our patient isn't taking any diuretics or medications that are going to require renal clearance or affect renal clearance. Let's move on to the cephalosporins. Our cephalosporins occur in generations. So we have our first generation, second, third, fourth, and fifth generation. We'll touch on those in a little bit of detail in a minute. But our cephalosporins are semi-synthetic antibiotics. They're chemically and pharmacologically very similar to our penicillins. They inhibit cell wall synthesis, and so they have a bactericidal action. The classes, the first, second, third, fourth, and fifth, these generations are built on the basis or classified on the basis of their spectrum of activity and their susceptibility to the beta-lactamases. So agents in the first generation tend to have good gram-positive coverage and, well, I would say excellent gram-positive coverage, but minimal gram-negative coverage. Whereas in the higher generations, they tend to possess the reverse in their spectrum of activity. So our first generations you may recognize as Cefazole or Cefadroxil and Cef, Valisef, Keflex. They treat things like our E. coli, our Proteus mirabilis, our Streptococcus Streptococcus pyogenes, our Staphylococcus epidermis, Staphylococcus pneumoniae. We also use them in surgical prophylaxis. So with our second generation, we get good gram-positive coverage, better gram-negative coverage than the first. So this is our Ceclor, Cefsil, Cefoxitin, or Mefoxin, Zinacef. You might recognize some of those names. More treatment is going to be in these with IV or IM, prophylactically used for abdominal or colorectal surgery because it also kills anaerobes. That's our Mefoxin. Our Zinacef is a parenteral form and Ceftin is PO form of it. The difference in the cefoxitin and the cefuroxime is that the cefuroxime does not kill the anaerobes. It's really good with our Neisseria, though, and our Enterobacter. Our third generation of cephalosporins is the most potent group against the gram-negative, with less active against the gram-positive. Examples of this are Clefiran, Fortaz is probably the one you'll see most, maybe the Rocephin. You see the Rocephin used a lot as a single injection. And the reason is because of compliance. So when we can give the patient a single dose of something and it completely takes care of it, that's a good thing. Then we don't have to worry about them building a superbug because of non-compliance. So it is given IV and IM. It has a really long half-life. We can use once-a-day dosing with the Rocephin. The elimination is primarily hepatic. But the other thing about Rocephin is that it easily passes the meninges and diffuses into the cerebrospinal fluid. So it can treat central nervous system infections, which is really a good benefit. Our third generation Taz, Fortaz, Tazidime. These are IV and IM, excellent gram-negative coverage, used for very difficult to treat microorganisms like our Pseudomonas. Its resistance is starting to limit its usefulness, unfortunately. Our fourth generation cephalosporins, this is our broader spectrum of antibacterial activity than the third generation. So if we were giving out pluses and minuses, the fourth generation is actually kind of equal. It's 3 plus and 3 minus. So it's positive and minus in terms of positive gram-positive bacteria, gram-negative bacteria. And this is actually generally reserved. We will sometimes see it given for uncomplicated and complicated UTIs in our Maxipeme, but clinically speaking, it's generally reserved for pretty severe infections involving gram-negative bacilli, particularly if we're treating a strain of Pseudomonas that's not responding to that third generation. Our fifth generation is Teflaro. This is ceftaroline. It has an even broader spectrum of antibacterial activity. So it's been around since about, 2010 maybe, and it is able to treat that methicillin-resistant Staphylococcus aureus, as I said, but it also treats Streptococcus pyogenes, Streptococcus aglanate, E. coli, Klebsiella pneumoniae, Klebsiella oxytoca. So it's a pretty new and pretty effective drug. With our cephalosporins, our adverse effects are similar to the penicillins. We'll see mild diarrhea, abdominal cramps, rash, pruritus, redness, and edema. And we do get potential cross-sensitivity with penicillins if there are allergies. Let's touch on the Carbapenems. This is our broadest antibacterial action of any of the antibiotics to date. They are spectrum beta-lactam antibiotics, and they derive their very potent activity from this resistant to bacterial beta-lactamases. They have a specific affinity for the penicillin binding protein 2, and they lack a permeability barrier. So they can act against some of the more serious infections, and they're reserved for very complicated body cavity and connective tissue infections in acutely ill hospitalized patients because of this. Also, because they may cause drug-induced seizure activity, which can be reduced with proper dosage, we don't typically see these given outside of that setting. With these medications, you'll see the Primaxin, that's imipenem, Scyllastatin. This is used for treatment of bone, joint, skin, and soft tissue infection. And the Scyllastatin actually is not an antibiotic component. It just inhibits an enzyme that breaks down the imipenem. The imipenem can actually cause abnormal liver function tests, thrombophlebitis, and then, of course, the seizures that we talked about. The Scyllastatin helps us to avoid nephrotoxicity, but it's needed to break that medication down. With our, excuse me, didn't mean to do that yet. With our Carbapenems, Carbapenems. Okay, so by now you're just laughing, right? These medications can also, particularly the meropenem, can cause agranulocytosis, neutropenia, Stevens-Johnson syndrome, and angioedema. With these medications, we just want to be sure that we are monitoring their liver and monitoring for seizures. We will take a quick break, come back, and talk about the monobactums. So I'll see you in a few minutes.